Yeah, my laptop stopped recording randomly, so we'll go through all of these again. So we have psychotherapy. Now, psychotherapy, there's only three things you need to remember. That is cognitive behavioral therapy for a majority of the conditions. And then you can give dialectic behavioral therapy for patients with borderline personality disorder. And then motivational interviewing for substance use disorder. This could actually be any kind of substance use. It could be cocaine, alcohol, cannabis, amphetamines, anything. You can do motivational interviewing for all of these patients. Next, we have stimulants. Now, stimulants basically they increase the amount of catecholamines in the synaptic cleft, and majorly they'll increase norepinephrine, and the symptoms will reflect that you'll have more of a sympathetic state, which is you'll develop nervousness, agitation, anxiety, insomnia, a decrease in appetite. Now, the decrease in appetite that I was saying, that is actually important for treating binge eating disorder. The problem is that in binge eating disorder, these patients already are eating a lot, and now because they're eating so much, you can give them a stimulant medication and you can suppress their appetite. For narcolepsy, the reason why you want to give these patients stimulants is because of the daytime sleepiness that these patients have. And in addition to stimulants for daytime, you also will need to give patients with narcolepsy sodium oxybate for night to help them sleep better. Finally, we have ADHD. Now, for ADHD, what we do is first line we give them methylphenidate, which is a stimulant amphetamine, and then if methylphenidate does not work, or the patient does not want a stimulant medication, then you can switch them to a medication called atiamoxetin, which is a non-stimulant medication. Okay. Next, we have antipsychotic medications. Now, there are two different types of antipsychotic medications. You have the typical and the atypical. The typical are called the first generation, and then atypical are the second generation. Now, the difference between these medications is the receptors they affect. Typical antipsychotics, they affect the D2 receptor, and then atypical antipsychotics, they affect the serotonin receptor. Now, there's multiple different antipsychotics, and you don't really need to remember all of these. I'll tell you that these are the most important. You need to remember risperidone, olanzapine, and clozapine for atypical. And for typical, you do need to remember these three: haloperidol, thioridazine, and chlorpromazine. So these are the six you need to remember. Now, why are we remembering only these? It's actually interesting because haloperidol, anyone who comes in very agitated and you immediately want to calm them, you can give them haloperidol as an injection. That's why you need to remember haloperidol. Uh, thioridazine, you want to remember because it can cause retinal deposits, which is a very unique symptom. And then chlorpromazine, you need to remember because it can cause corneal deposits, which is again a very unique side effect. On the other hand, for atypical antipsychotics, you need to remember olanzapine because we use this medication for the treatment of anorexia nervosa. And the idea is that it can cause uh, increased hunger in the patients, and that's why we want to prescribe them this medication. Next, we have risperidone. Now, you want to remember risperidone because this is one of the medications which can cause hyperprolactinemia, which is again a very unique side effect. And finally, clozapine. Now, clozapine is a really good medication if the patient has resistant psychosis, where the patient has tried like 2 or 3 different medications and they've not helped with the psychosis that the patient is suffering from. And in those cases, you can give the patient clozapine. Additionally, clozapine is one of those 2 medications, one of the only 2 medications, which can actively decrease the risk of suicide. One is lithium, and then the second one is clozapine. So those are the medications you need to remember. Now, let's quickly go through the side effects that we see with antipsychotic medications. Obviously, we said that patients who use risperidone can develop hyperprolactinemia. However, with these atypical antipsychotics, you have a much higher propensity to develop metabolic syndrome. Now, metabolic syndrome is a triad of these three symptoms, which is weight gain, hyperglycemia, and dyslipidemia. For clozapine, you have a very unique side effect, two which you do need to remember, which is agranulocytosis and then myocarditis. Now, what problem do you think these patients will have if they develop agranulocytosis?
Increases the infection.
Yeah, it will increase the risk of infection because of the agranulocytosis. So the USMLE might not tell you that agranulocytosis is happening, and instead they might tell you that, oh, this patient has developed multiple infections recently. Okay. Finally, we have the extrapyramidal symptoms. Now, the extrapyramidal symptoms, they're usually a side effect of these typical antipsychotics. And in these typical antipsychotics, right, we calculate the potency of these antipsychotics. So anything which is lipid soluble has a high potency, and anything which is insoluble has a low potency. Now, except for three medications, all of them are except for haloperidol, which you need to remember for high potency, and these two medications which you need to remember for low potency, you can kind of forget the other ones. I would tell you that maybe you can remember the flu. Yeah. So just remember high potency is haloperidol and medications which have a flu in them. So flufenazine, trifluoroperazine, both of these. See, both of them have a flu. So the high potency antipsychotics, right? They can have a much higher risk for development of extrapyramidal symptoms. And there are three extrapyramidal symptoms that you need to remember. The first one is acute dystonia. And we already discussed what acute dystonia looks like, where these patients have a muscle spasm and it resembles torticollis. So something similar to a spasmodic torticollis. And the treatment would be benztropine. Now, benztropine is a good treatment because it works for a majority of these extrapyramidal symptoms. And the reason why it works is because of M1, muscarinic receptor 1 effect. So the earliest extrapyramidal symptom that you can see is acute dystonia. After acute dystonia, the other symptoms that you can see in like a moderate time frame are akathisia, which is simply restlessness, and Parkinsonism. So it won't be. So basically, what happens is you won't really see as severe symptoms as Parkinson's disorder, and they won't be progressive. Instead, they'll be fixed in a certain stage, and they'll have these Parkinsonian symptoms. So less intensity and not progressive. That's the difference between Parkinsonian symptoms and actual Parkinson's disease. Finally, if the patient is taking antipsychotic medications for a very long time, so from months to years, these patients can develop tardive dyskinesia. Now, tardive dyskinesia, and one of the things that they'll always give you, right, is that the patient is sticking their tongue out. And the idea here is that these patients have like profound they have profound muscular motor problems, and usually it will be in the entire body, but mostly it will affect the face. The treatment here is benzodiazepines, though you can also use benzodiazepines for akathisia. So any questions until now with the antipsychotic medications? and the behavioral therapies.
So, Dr. Taha, you said we are treating tardive dyskinesia with benzos?
Yeah,
Okay.
that is the most viable option. Obviously, you can give them these other like medications, but the USMLE really doesn't ask you about all of these other medications. They only want the benzodiazepines. Okay. So next we have lithium. Now, lithium actually has a different classification, and that it's not an antipsychotic, it's not an antidepressant. Depressant. It's actually a mood stabilizer, and the way it works is that it just modulates neurotransmitters. And what it does is it will decrease the excitatory neurotransmitters and increase the inhibitory neurotransmitters. Now, obviously, we're using it for bipolar disorder. However, the side effects here they're pretty, I'll say, weird, where you can develop some kind of thyroid problem. It could be either hypothyroidism or hyperthyroidism. It could be either one. Doesn't need to be a specific one. You can develop nephrogenic diabetes insipidus, Epstein's anomaly, which is a cardiac anomaly, and then okay, yeah, sorry. These are the side effects. So now, what do you think? What would be the most important sign for hypothyroidism?
Weight gain?
Not weight gain. There is one which is like even more important, because if you see the symptom in a patient who is completely normal, you can still assume that this patient might have hypothyroidism.
Hyper or hypo?
Hypo.
Could that
Depressive symptoms?
yeah, depression?
No, not depression. Usually it will be the heart rate.
Oh,
Bradycardia?
bradycardia.
Yeah. So the heart rate is the most important symptom you need to remember for these thyroid conditions. Because sometimes they might give you a completely normal patient with only a slight decrease in heart rate. It's not slight, okay, it'll be somewhere around 60s or 50s. And they might just ask you, oh, what electrolyte, not electrolyte, but what hormonal imbalance does this patient have? And then you can mark thyroid as the answer. Now, next we have nephrogenic diabetes insipidus. Now, nephrogenic diabetes insipidus, basically what's happening is your body is producing antidiuretic hormone, but your kidneys are not responding to the antidiuretic hormone. And that is why you have increased urination, so you have polyuria. And along with the polyuria, you also have fluid contraction, so you have a volume contraction and increase in osmolarity in the serum. Next, we have teratogenic effects of lithium, and that's actually Epstein's anomaly. And what happens in Epstein's anomaly is you have reduction in the size of the right ventricle. That means the right ventricle it's decreasing in size. That's Epstein's anomaly. Now, after all of these, right, there is one thing you need to remember for lithium, and that is that lithium is primarily excreted through the kidneys. Now, why is this part important? Because any kind of medications that you give these patients, which affect the urine flow rate, or it affects the production of urine, or anything that is nephrotoxic, can in fact change the serum concentration of lithium. And lithium has a very narrow therapeutic index. That means it's very easy to develop toxicities for lithium. Another medication which has a very low therapeutic index that you need to remember is warfarin. Yeah. And then what do you guys think? If someone has lithium toxicity, then what can you do to treat the patient?
Well, usually we would stop the medication. We'll give them a lot of hydration. Stop the medication, may have to convert to valproic acid, I think,
Yeah, that's
to
correct.
change. Yeah.
And like what's so let's say the patient came to you and you diagnose it as lithium intoxication. You stop the medication, you give the patient a lot of hydration, but there are still symptoms. So what's the last thing you can do? The last line option.
Oh, dialysis.
Yes. So you can put them on
Dialysis.
dialysis.
Yeah.
Now, there is one more interesting thing about valproic acid. For the treatment of bipolar disorder, you can also give the patient valproic acid. However, there are two things you need to consider. If you give the patient lithium, they will develop Epstein's anomaly, and then because of increased urination in pregnancy, you might also have to constantly monitor the dose of lithium. On the other hand, valproic acid is very likely to cause neural tube defects because it can cause a folate deficiency. So now you need to choose which of these risks are more acceptable for the patient because both of them have risks. So let's say the patient is sure that she will take enough folate, so then you can probably switch her on valproic acid. However, if the patient has previously tried valproic acid and has failed treatment, that means valproic acid didn't work on her properly, then you can switch the patient, not switch, but then you can continue the patient on lithium with these risks. Because if the patient develops a manic episode during pregnancy, then she might do something very stupid and it might damage the baby. Next medication that we have is buspirone. Now for buspirone, right, there's only two things you need to remember. That this medication can be given for generalized anxiety disorder and usually not given for depression, and that it's a partial serotonin receptor agonist. That's the only two things you need to remember for buspirone. And then finally we come to the antidepressants. SSRIs are the most important antidepressant medications because almost any of the psychiatric conditions, so depression, generalized anxiety disorder, panic disorder, OCD, bulimia, binge eating disorder, social anxiety disorder, PTSD, premature ejaculation, all of the, wait, premature ejaculation isn't a psychiatric problem. But all of these other conditions can be treated with SSRIs. So they're the most broadly used antidepressant. Now, there are a couple of syndromes that you need to remember that SSRIs can treat, which are not entirely psychiatric. And one of this is actually premenstrual dysphoric disorder. And basically, this disorder is a much, uh, I would say, worse variant of PMS, which is premenstrual disorder. Yeah. Okay. And this here is also important that you need to wait at least 4 to 6 weeks. Here it says 8, but 4 to 6 is also an acceptable time. That you need to wait at least 4 to 6 weeks before the SSRIs start their effect. Now, a lot of times, how these questions would be framed is that a patient comes to you, you've diagnosed her as having major depressive disorder, and that you started an SSRI. She comes back, maybe let's say 3 weeks later, and she tells you, oh, I still have these symptoms, I want to change my medication, or I want to increase the dosage. And then the response that you tell the patient is that, you need to give the medications more time because it usually takes like 4 to 6 weeks or 4 to 8 weeks to actually start its effect or to show its effect. Next, we have SNRIs. Now, these work very similarly to SSRIs, that they inhibit the reuptake of serotonin. However, for SNRIs, they're also inhibiting the reuptake of norepinephrine. So you have an increase in serotonin and norepinephrine in the synaptic cleft. Now, again, they're used to treat a lot of these conditions, psychiatric conditions. However, this is one medication that you should remember specifically, which is duloxetine, which is used to treat fibromyalgia. Additionally, because these medications also increase norepinephrine in the neural crest, you will see a stimulant effect as side effects. Okay. The adverse effects for SSRIs, there's three that you need to remember very well, because these are the most important ones that the USMLE asks you. So you have SIADH, which is the complete opposite, I would say, as not nephrogenic, but diabetes insipidus. So in diabetes insipidus, you had a decrease in effect of ADH. In SIADH, you'll actually have an increase in effect of ADH. That means you'll have oliguria. That means there is low urination. And along with that, you'll also have hyponatremia. So low sodium in the serum. And the reason why you have this is because you're essentially taking in more water from the urine. So you're diluting the serum. Now, what do you guys think? In patients with SIADH, because they are taking up a lot of water, what would be the serum level or serum volume level? Would it be hypervolumic? Would it be hypovolumic? Normal volume?
Hypervolemic, right?
Okay, so you say hyper.
Normal.
Someone said
Hyper,
normal.
because they are taking all the water towards the serum.
Yeah.
So they're taking water, right? So that would be hypervolemia.
Yeah, so that's correct only for the initial stages. However, like soon after the patient develops SIADH and they start taking in a lot of water, they'll actually go back to normal volume.
Yeah.
Yeah.
Euvolemic, yeah.
Yeah, so they become euvolumic. And then Soma, you said euvolumic. So what was your reasoning for euvolumic?
Can I say it?
Oh, yeah, sure.
Could it be because of the aldosterone escape mechanism?
Yes, that is correct. And then which hormone, I would say, mediates the aldosterone escape mechanism?
ANP and BNP, right? In the
Yes,
heart.
more specifically ANP. And then the idea here is that you have so much fluid. So the atria in the heart, they kind of stretch in response to the increase in volume. And that stretch will release ANP, which then has a diuresis effect. So that's heard. Okay. Now, similar to SNRIs, TCAs also work similarly, in which they inhibit the reuptake of norepinephrine and serotonin. Now, there are a couple of conditions that you need to remember that TCAs treat, and the most important one would be neuropathic pain, which is any kind of pain which is occurring in response to nerve injury. And specifically, this would be diabetic neuropathy, in which you have neuropathic pain. Now, here they do tell us that TCAs can be used to treat MDD. However, we don't really use TCAs for the treatment of MDD because we have we have a lot of other medications that we can use. So initially you would go with an SSRI or an SNRI. If that doesn't work, then you would go with the atypical antidepressants. And if that doesn't work, then maybe you can go with a MAO inhibitor. And then finally you can start a TCA. And the only reason why we start TCAs so late, even though they're very good for treating depression, is actually because of these side effects, which is that it can cause seizures, coma, and cardiotoxicity. The cardiotoxicity is actually arrhythmias. And in addition to all of these, they can also cause an anticholinergic syndrome. So there is a lot of side effects associated with TCAs, and that's why we rarely prescribe TCAs except for patients who have neuropathic pain. Now there is one more thing that you need to remember is that elderly people, they're at a much higher risk for anticholinergic side effects from TCAs. However, it's the elderly patients who usually develop the neuropathic pain from diabetes. So if this happens, if it's an elderly patient who has neuropathic pain, and we know that we want to give them a TCA, we actually give them a medication called nortriptyline, which is, let's say, a weaker version of amitriptyline, which is the most classic TCA. And we give them nortriptyline because it's well tolerated and it has a less propensity to cause anticholinergic side effects. Finally, for prophylaxis and prevention of arrhythmias, you can give them sodium bicarbonate. And what sodium bicarbonate does is it stabilizes the membrane, stabilizes the myocardium. So that's for TCAs. Now, next we have MAO inhibitors. Now, for MAO inhibitors, right, you need to remember that these MAO inhibitors, they increase the amount of amine neurotransmitters, and they do this because they're blocking MAO. So, as the name says, monoamine oxidase inhibitors. So, they increase the amount of monoamine neurotransmitters in the synaptic cleft. And these are norepinephrine, serotonin, dopamine, all of these. Now, for treatment, most importantly, I'll tell you that the most important treatment that they're used in is Parkinson's, because we still use them for Parkinson's, and atypical depression. However, again, for atypical depression, you wouldn't necessarily give MAO inhibitors as the first line medication. You can still start them on SSRIs or SNRIs, and then if those medications do not work, then you can pick MAO inhibitors. Now, similar to TCAs, MAO inhibitors also have some very bad side effects. These are hypertensive crisis, which we already discussed, that whenever a patient is taking MAO inhibitors and they accidentally consume anything which is fermented. So it could be fermented cheese, it could be wine or cured wheat, anything which has some kind of tyramine. So whenever they consume anything with tyramine, which is usually those fermented foods, they can develop a massive hypertension, which can be fatal. Additionally, because these medications are increasing serotonin, these medications can also cause serotonin syndrome. And all of these medications, right, even TCAs, because they're increasing serotonin, can cause serotonin syndrome. SNRIs can cause serotonin syndrome. SSRIs can cause serotonin syndrome. So all of these medications can cause serotonin syndrome. However, the likelihood of developing a serotonin syndrome because of MAO inhibitors is much higher compared to the other ones. Okay, so so what you guys said, should we continue with the medications? We only have the atypical antidepressants, or do we start questions?
Dr. Taha, let's finish the atypical antidepressants.
Okay, perfect.
It's only one page now.
Yeah, it's only one page, and a lot of these medications, they're very easy. You don't really need to remember a whole lot of detail in these. So for the atypical antidepressants, these are usually second line medications after SSRIs. Or let's say the patient has some specific symptoms or comorbidities along with depression that you want to treat. So in those cases, you can give these patients these atypical antidepressants. So let's start with bupropion. Now, bupropion, it inhibits norepinephrine and dopamine reuptake. So that's important. It doesn't really affect serotonin. And this is the second best medication that you can use, or the second best method that you can use for smoking cessation. Do you guys remember what the best method is for smoking cessation?
Bupropion.
Oh no. So bupropion second
Something
best.
something name with a V. Were some I
Yeah,
forgot the name.
Oh,
varenicline.
the brand.
Yeah.
Yeah, brand name is called Shintex. I can't remember the generic name.
Yeah,
Shintex.
varenicline for
Oh,
that
there you
that's
go.
the best medication for smoking cessation. And then what's the least effective for smoking cessation?
That I don't know.
So nicotine replacement. That's the uh, like third best, I would say, third best supplement for nicotine. So nicotine replacement is the third best alternative for smoking. Also, give me 1 minute. I'll be back. I'm back. So bupropion for smoking cessation, second best. And then one thing about bupropion, right, is that it does not increase the risk. So it decreases the risk of sexual adverse effects, which are usually seen with SSRIs. See, SSRIs and SNRIs, they both can cause sexual disturbances. So you don't see that with bupropion. Finally, one thing here is that you cannot give patients with bulimia or anorexia bupropion because it will increase the risk of seizures in these patients. And it's not actually limited to bulimia and anorexia. Anyone who has a electrolyte abnormality should not be given bupropion because it can increase the risk of seizures. Next, we have mirtazapine. Now, mirtazapine is actually an alpha 2 antagonist, and because of that, it will increase norepinephrine and serotonin in the synaptic cleft. Now, the adverse effects, no, sorry, I wouldn't say adverse effects because these in a few people are desirable effects. That mirtazapine will increase the weight. So if it's a, let's say, underweight patient who also has depression, you can give these patients mirtazapine and it will increase the weight. Additionally, because it's also sedative, these patients might also be able to sleep better. So let's say a patient has depression, he's not sleeping well and he's not eating well. So then for these patients, mirtazapine would be a better medication compared to SSRIs. Next we have trazodone. Now trazodone, it only blocks the, not only, but it blocks the serotonin receptors. And what it means by block serotonin here is just the reuptake. It blocks the reuptake of serotonin. Now there's other mechanisms here, but I would only tell you to focus on the serotonin. Now, similar to mirtazapine, trazodone can also help with sleep. And the most important thing you need to remember here is this part, priapism. Trazodone can have priapism as a side effect, which is a sustained penile erection for more than 4 hours, which can result in necrosis. So that is one side effect. And then it can also be used for sleep, to induce sleep in patients who have depression. Now, both of these medications, vilazodone and vortioxetine, they're not the most important to remember. And even if you look here, you can kind of see very non-specific side effects. So they have headache, diarrhea, nausea, anticholinergic, and serotonin syndrome. But that's true for all of these medications. So just remember that both of these block serotonin. And even if you don't remember these are all right because these medications are not asked.
I wanted to verify. You said the number one best drug for smoking cessation was varenicline.
Yes,
Varenicline. Okay.
yes,
Thank you.
no problem. So next we actually have the pharmacotherapies for smoking cessation. So, I mean, we already know these, right? Um, what these medications do, they'll bind into the nicotinic receptors because nicotine is the active ingredient or the active compound in cigarettes. And that nicotine withdrawal, it's actually considered one of the worst withdrawals. So it's nicotine, alcohol, and opioids as the worst withdrawals. There'll be multiple different symptoms that these patients have. And you can use a couple of things here. You can use patches, the lozenges. So all of this would be nicotine replacement. You can use varenicline, and then you can also use bupropion, which we already covered. So nicotine replacement, obviously they're working as like full agonists at the nicotinic receptor. And varenicline, on the other hand, will work as a partial agonist. And it's much more long acting. So this will reduce the withdrawals. And in addition to that, it can also reduce cravings. One interesting thing here, right, is this side effect, sleep disturbances. And specifically, the sleep disturbance that you see with varenicline will be nightmares. Finally, we have medically supervised opioid withdrawal and relapse prevention. So basically, this is for anyone who has opioid use disorder, and now maybe the patient is intoxicated, or if the patient needs to be treated for the use disorder. So either one of these, you can use these medications. So for these medications, majority you need to remember, or the most important thing you need to remember, is the mechanism of action. And except for that, other things they're not as important. So for methadone, remember that it's a long-acting opioid, and that it can be used as maintenance therapy for like a longer term. Buprenorphine is a partial opioid agonist, and the one good thing about buprenorphine is that, not good thing, but I'd say rather bad thing, is that because it's a partial agonist, right? It can actually precipitate the withdrawal symptoms in anyone who has opioid use disorder or is physically dependent on opioids. Let's say someone recently used opioids and now is intoxicated. So in that patient, if you give them buprenorphine, it can actually increase the chance that the patient will show immediate withdrawal. And then that is not something you want to subject the patient to. So we would avoid buprenorphine. Next, we have naloxone and naltrexone. Now, these seem relatively similar, and the mechanism is similar. That naloxone is a short-acting opioid antagonist, and on the other hand, naltrexone is a long-acting opioid antagonist. Now, this is important to remember that naloxone is short-acting and naltrexone is long-acting. The reason is because sometimes they might give you a timeline where they ask you like what time will, not what time, but which of these medications would be longer acting. And then for those conditions, you do need to remember the time frame. Naloxone, short acting, and naltrexone for long acting. And one more thing for naloxone is that it's used to treat acute opioid overdose. And it's a very good medication because, not uh, because, but it's a good medication for anyone who has opioid use disorder. And it's good because you want to prevent overdose, and you want to prevent death because of opioids. And so that's why you usually tell anyone who has opioid use disorder to carry naloxone. Naltrexone, as we said, it was long acting, and this is important for naltrexone that it may help for alcohol and nicotine cessation. And the way it works is that it reduces the cravings. So you can, in theory, use these medications, naltrexone for alcohol and nicotine cessation. But I would say it's more important for alcohol cessation compared to nicotine cessation, because for nicotine we have other medications. Yeah. So that is all of pharmacology. Do you guys have any questions?
No,
No, please. Thank you.
thank you.